sensitivity analyses to see if that was driving our results. The reviewers of the paper suggested we exclude all prostate patients as a sensitivity analysis to see if the hazard ratios for OS and PFS remain less than 1, recognizing that taking out 18% of your patients will lower your power. Nonetheless, the results still hold. We also did a multivariable analysis for OS and one for PFS to control for histology. OS is shown here, PFS is shown here, and the results still hold. So we are fairly confident that the prostate patients are not driving our primary conclusion. We have some limitations. This is not a histology-specific trial, and most SRS SABR trials are not. The brain trials we've seen, the spine trials, and although a histology-specific trial would be ideal, the populations are smaller and the numbers are lower. If we had done this as population-specific, we'd be presenting in about 2045. We allowed a pragmatic selection of systemic agents because it was impossible to mandate in 2011 what the chemo should be given the multiple disease sites and the expected changes in standard of care over time. And because it's a phase 2 design, the OS results are not definitive, and the OS results are not mature. It exceeded our expectations, but you'll notice that at 3 years and beyond, there are still a lot of patients alive and at risk who were censored, particularly in the SABR arm. So we have amended the study to follow patients for 10 years. So the question today, is a clear and definitive PFS benefit enough to treat? And the answer to that question really is up to you. But I'll make the argument that there's ample precedent in oncology. When aromatase inhibitors came in for breast cancer compared to tamoxifen, there was only a PFS benefit for the first decade. And for those of you who treat lung, you'll note that crizotinib had the same phenomenon, a PFS but not an OS benefit. And ultimately, the majority of FDA approvals for cancer drugs are not based on OS. So our next steps, up in Canada with our collaborators, we are launching SABR-COMET 3, a phase 3 randomized trial for patients with 1 to 3 metastases to try to confirm the OS benefit. And we're also launching SABR-COMET 10 for the patients with 4 to 10 metastases. That is funded and is going to be opening in just a couple of months. This is the schema for SABR-COMET 10. The major principles are minimizing toxicity, we are lowering the SABR doses, and to minimize treatment time so patients can get on to systemic therapy. In conclusion, SABR was associated with an improvement in OS, meeting the primary endpoint of this trial. PFS was doubled. Toxicities were more common with SABR, with a 4.5% risk of treatment-related death, but no decrease in quality of life. To our knowledge, these findings represent the strongest clinical evidence available in support of the oligometastatic state across multiple tumor types. And you might want to point out in your tumor boards that this is a higher level of evidence than exists for any surgical intervention for oligometastatic disease. If your surgeons are mad, send the questions to me. I want to acknowledge my co-PI and mentor, Professor Suresh Senin, from the VU University in Amsterdam, and also Drs. George Rodriguez and Glenn Bauman, who mentored me through the design of this project. For further information, the protocol is available in BMC Cancer Open Access, and the manuscript will be published in the next few weeks in The Lancet. Thank you for your attention.